Good evening. Thank you very much for coming. It's really a surprise to me to have so many people come, and thank you very much. So, who am I? So I think lots of people will say, who is this guy? So I can give some brief introduction. I did my medical school in China a long time ago. Then I did my orthopedic residency at the Wake Forest University, Bowman Gray Medical School in North Carolina. Then I did my upper extremity fellowship at Duke University. So then I joined Springfield Clinic 6 months ago. So right now I'm specialized in hand upper extremity surgery in the Orthopedic Group in Springfield Clinic. So we have been here for 6 months. We had a great experience. We have a good patient, and we have a great outcome. And we feel confident. We have lots of patients. They're very happy, very good. So for me, I have been doing like a research and a clinical study for like over 20 years in peripheral nerve injury and repair. So initially I was a physician in China. Then I was a scientist. I did lots of research, very extensive research background in China and in the States. Then I did residency and be a physician again. So I'll be physician, scientist, physician. So I really enjoy what I did in the past because this really gave me a lots of opportunity. Say I found this question, then I went to the lab to do a lot of study to find the answer. Then bring the answer to my practice. I really feel like I made a big difference because I really understand this much better than before, So I think, for me, I really enjoy the experience, and also I think my patients really appreciate, all this like training in research and clinical practice. So, so tonight we're going to talk about numbness and tingling. This is very, very common in our daily life, and also in our clinic. Patients say, "Hey, I have numbness and I'm tingling." Very, very common. You will hear lots of people say, "Hey, I got carpal tunnel syndrome. I got carpal tunnel syndrome." And then people say, oh, wait a minute, what is carpal tunnel syndrome? What is carpal tunnel syndrome? Is tunnel syndrome so close? So they came to ask us, what is this? So I think, we talk to lots of patients, and they feel, if you can give us some information in this field, it will be great. So that's the idea we want to do this topic. So, so let me start a case presentation. About probably 2 years ago, actually, this is a friend of mine who's a musician. He played guitar to make a living. He's a 40 years old male, and he called me one night. He said, like, "Hey, recently I had some numbness and tingling in my small finger for about a month. And it's really bothered me because I'm using my hand to play guitar." And he said, like, my secretary was diagnosed with carpal tunnel syndrome because of numbness tingling. He's asking me, is this going to be the same problem? Is it carpal tunnel syndrome again? And then the real question is, say, hey, I'm busy. I'm doing like a new album. I cannot come to see you. Can I wait for a few months, for this problem? Then, what should I do, if I have carpal tunnel syndrome? So for all this type of questions. So I feel like that's pretty common. So, this is 40 years of male using hand and knot, has some numbness, tingling, and I have some questions. I think probably like most of the people like this. So when we talk about numbness and tingling, usually we'll start with some basic anatomy. In our human body, we have two systems in our body. One is a peripheral nerve system, one is a central nerve system. Central nerve system is a brain and including brain and the spinal cord. And the peripheral nerve system, like a bridge, bring your brain to the finger or to the feet. So you can move your finger so you can feel what you have in your finger. When you have any injury here, then you have trouble to control your finger, say to react to the flame, and you'll have trouble to feel this hot. So peripheral nerve is very, very important in our daily life. There's fundamental structures in the peripheral nerve. There's some fiber types. There are 3 types of nerve fiber. When we talk about peripheral nerve system, we have 3 types. Nerve fiber. One is sensory type nerve fiber, which is responsible for sensation. And then second will be motor fiber. You can see here the color. And also there's one type we call autonomic fibers, which is responsible for sweating. When you have nerve injury, some people say, hey, my hand is very dry. And sometimes say, oh, my hand not sweating. All these indicating you have some nerve dysfunction. So lots of people was asking me, say, hey, what is the nerve? How the nerve looks? I know the bone is white, very hard, and I know the muscles are red, soft. What is a peripheral nerve? So with our eye, naked eye, we can see the nerve. It's like a band in the forearm. Probably just the size about 4 or 5 millimeter. You can see from here. In the neck, probably bigger, sometimes up to 1 centimeter. And if you use like a loop magnification, you can see some tiny vessel here on the, see the vessels on the nerve. And if you have some patient, they have some cut, you can see the vesicle come out this nerve. This is a nerve, if we use our eye. So over the past 100 years, people have been looking at what kind of structure inside the nerve. So we can use a microscope. And we do staining. We cut the nerve. You can see this is a nerve fiber. You can see this. And if we do cross-section, just cut nerve transverse section, you can see all the circle. Each circle is a nerve fiber. Here's an electron microscopy. With this, we can see even detailed structure in the nerve. You can see all this nerve. This is huge. Actually, this size of the nerve is about 10% of the size of our hair. It's extremely, extremely small. So from this slides, we know the nerve fiber are very, very small, very fragile. They are very easily damaged. So we know the nerve fiber come from the brain, from the spinal cord, and to our hand. There's no pathway. But anywhere along the pathway, got injury or any compression will cause problem. Then you will have some numbness, then you have tingling. This could happen anywhere from the hand to the spinal cord. And very interesting, people will say, why I have numbness, tingling first? Why I did not have weakness first? Here's the answer. The sensor fiber usually is small. The motor fiber is large. Usually a small fiber is more susceptible to nerve injury. So that's why every time you have nerve compression, people say, hey, I always have numbness, tingling first. And in a couple of years, I have some weakness or muscle atrophy. So that's why you have numbness, tingling before the muscle weakness. This is some scientific evidence here. So nerve injury could be acute, also could be chronic. This type of pattern of the injury will give some different presentation. If you have acute injury, you cut the nerve, usually we'll see, hey, I cannot feel my finger. Just you cannot feel anything. There's no numbness, tingling, or maybe some, but most of the time you say, I cannot feel anything. You don't have any sensation, and the muscle will atrophy quickly. For the chronic injury, compression, most of the people say, hey, I still can feel there's something, but I have numbness and tingling. In other words, if you say, I have numbness, tingling, most of the time you have some chronic nerve injury. And over time, probably you're going to have the same outcome, like you can lose sensation, you your muscle will be atrophy. So that's why you need to address this quicker. You don't wait like too long, end up with like a functional problem. So lots of time we, if we do go to doctors, do nerve study, we'll say, hey, you have mild injury, you have severe. So there's some classification for the nerve injury. That's why we say, hey, I got severe nerve injury, I got mild. Why you say this? There's some physiological evidence behind this classification. And if you say the mild injury, you will see we don't have much signs, but you will see some change on the scope, on the microscope. If you say I have severe injury, you will see muscle wasting, you can lose sensation, and also you can see all the structure change under fluoroscopy or under electron microscopy or staining. So let's talk about the hand. There are 5 nerves helping our arm. There are 3 nerves responsible for sensation in our hand. We have a median nerve, we have ulnar nerve, and radial nerve. Median nerve mainly for this 3 finger, and ulnar nerve mainly for this 2 finger, and radial nerve mainly on this side. And you can see this one actually will give you better pictures. See from here, you can see all these 3 fingers are innervated by median nerve, and these fingers are innervated by ulnar nerve. And on the back side, it's a radial nerve. So this will give us information, say, if I have numbness tingling in a small finger, as the first case I present to you, my friend, he had numbness tingling here, that's ulnar nerve problem. If you say I have numbness tingling in my thumb and my index finger, we know that's a problem from the median nerve. If I say, hey, I have numbness tingling on the back of my hand, then we'll say you have trouble with the radial nerve. So, sorry, gosh. There are not nerve compression syndrome in our hand from these 3 nerves. The 3 nerves compression syndrome in the median nerve, and 2 relate to ulnar nerve, and 3 relate to radial nerve. You don't need to know all this. This is our job. But you will know carpal tunnel syndrome is the number 1. It's the most common nerve compression syndrome in the hand. And the number 2 is carpal tunnel syndrome. This is number 2. So this is from ulnar nerves. You will see probably most of the patients say, hey, I have trouble with my hand. You will know most of the time from carpal tunnel syndrome. This is from median nerve, and the other one will be carpal tunnel syndrome from ulnar nerve. So we're going to focus this 2 tonight. There are some systemic disease also affecting nerve compression syndrome, especially in this country. First, number 1 is diabetes, and thyroid issue, collagen issue, and like lupus or rheumatoid osteoarthritis. Also, chemotherapy relate neuropathy, alcohol, vitamin issue, and heavy metal, Lyme disease, even sometimes AIDS. So this is our forearm. We know there's 2 joints. We use this very often, every day. Number 1 is the wrist. Every time we move the hand, we have to move our wrist. The second one is the elbow. We have to move our elbow. It's interesting. All this syndrome actually relate to the frequency we use our joints, because we use the wrist as most. That's why we have carpal tunnel syndrome most common. It's very interesting. So let's look at some demographic information for the carpal tunnel syndrome. We know every year we have like 1, 2, 3 new patients among every 1,000 people for carpal tunnel syndrome. We have like 5% people will suffer from carpal tunnel syndrome. And people with diabetes, they will have a much higher risk to suffer carpal tunnel syndrome. Unfortunately, the female also have more chance to develop carpal tunnel syndrome, and the dominant hand usually is first. Overall, everyone have 10% chance in our whole life suffer this problem. So this is very, very common. And so what is the carpal tunnel? Every day we say carpal tunnel syndrome, carpal tunnel syndrome. What is the carpal tunnel? So here's some information here. This is a very narrow passageway on the palm side of the wrist. And it's very solid. It's built by a bone with tendon with a ligament. The tunnel is not forgivable. It's very solid, very tight. And it's very small. It's about half of the size of a dime. But there's 9 tendons and 1 nerve through this little tunnel. So it's jammed. It's very, very, very tight. And the nerve, the size is very small, like 10 millimeters, very small size. But we know there are more than 7,000 nerve fiber in this tiny nerve. So you have some idea that because the fibers, how small, you can appreciate that. So every time you move the wrist, you're going to cause some increase of pressure, and you can get the tunnel inflamed. Then increase the pressure, then cause a nerve issue. That's why you have carpal tunnel syndrome. So let's look at the symptoms. What kind of symptoms you have if the patient developed carpal tunnel syndrome? Most common you will see numbness, tingling in the index and the middle finger. Sometimes in the thumb, it's not very common. So most of the people say, hey, I have numbness, tingling in this 2 finger. And then also they will say, hey, I have to wake me up at night because of this numbness, tingling. I think, from my experience, these 2 symptoms basically will give me probably 80 to 90%. If I ask a patient, where you have numbness, tingling, does it wake you up? If they say yes, I think 80 to 90% they have carpal tunnel syndrome. I don't even to do any test. Some people also have some muscle wasting. This is not common, very rare. And also sometimes people say, hey, I cannot hold my little pencil, or sometimes I'm holding something, some just dropped. I didn't realize this. All these are very, very common. Number 1, number 2, extremely common. We do some testing sometimes for diagnosis. Before that we check the history, exam and signs, symptoms and signs, and we do the exam and check the sensation and check the muscle strength, and also some exam with design to test the nerve function. There's 3, we'll do this test, every time we examine you, there's some 3 tests, very common. Every time the doctor will ask you, do this. Actually, there's some reason to do this. And you can see this is a carpal tunnel syndrome patient. You can see they have numbness, tingling here, and we do all this testing. Sometimes we order X-ray to make sure there's no fracture, no osteoarthritis. Sometimes it can contribute to the problem. Sometimes we order nerve study to check the damage in the muscle, and also we check the nerve conduction, because nerve conduction will slow down across the tunnel, and also we can rule out other problems. So there's some risk factors in carpal tunnel syndrome, like this is a structure issue because of the fracture, or female, usually the tunnel is smaller, so that's why they have a high chance. And also some other medical condition with diabetes, with the alcohol, and some inflammatory condition like a rheumatoid osteoarthritis. Also, the balance of the body fluid. People in pregnancy, usually they have much higher chance to have carpal tunnel syndrome. So if you talk to people, hey, I have all this issues, this basically some red flag. They have a higher chance to develop carpal tunnel syndrome. And also repeated motion at work also is a problem. So here's some scenarios very common in our daily life. When we type, make sure you have a right position. This is a great for ergonomic education. If your wrist is all to deviate, this will cause problem. If your wrist does not extend too much, this will increase the pressure, will cause problem. And when you drive, you put your wrist on the wheel, and you have too much pressure on that. And when you play a game, you do this all the time, 4 or 5 hours. So it's interesting for the young patient. If sometimes a 15, 16-year-old little kid come here for numbness and tingling, we ask them, what happened to you? They say, hey, I'm playing like a game for 10 hours for a few days. So that's very new in the past probably 10 years. So there's some risk in this occupation. You see a worker, and farmer, and also machinist, and gardener, and musician. They have very high risk to develop carpal tunnel syndrome. The good news is carpal tunnel syndrome is very common. The good news is that we can manage this with non-surgical treatment. So even we are surgeons, but we see patients every day. Most of the time we are helping patients with no surgery. So that's good news. Probably 85–90% people, they are very happy. We just give some injection, give the brace. They do not need surgery. So usually we start with the activity modification. So we ask them, hey, switch your hand, change your position, just, don't overuse your hand. This will help a great deal. Sometimes take some ibuprofen. Also, bracing is very important. There's two types of brace. One is we call neutral position brace. You have to wear this at night. The other brace we call functional brace at daytime. So these two braces should be different. Because lots of time I ask patients, say, did you wear a brace? Yes, I'm wearing a brace. Are they the same? Yes, same. That's a problem. If you wear the same brace during daytime and at night, it's a problem. You should use two different braces, or at least you change the contour when you wear this at night or at work. They are different. Also, we can give injection. 85% time, the people, they will respond to injection very well. Very well. Sometimes they help about a year. They do not have any trouble with that. Probably 10% people, they end up with surgery. No matter what we do, they say numbness just progressing. I have to wake up every night. I cannot sleep. Then we offer surgery. So there's two types of surgery. One is open surgery. One is we use a scope. Open surgery basically simple. You just release a ligament, release a nerve. You can see from here. You can see some compression, some indentation on the nerve. You can see from here. Actually, this is from the ligament. And sometimes we do scope release, which is very popular probably 15 years ago, but it's not popular anymore in this country because the complication rate is much higher than open surgery today. So after surgery, people say, what am I going to do after surgery? You will keep your hand elevated, you change your dressing a few days, you move your finger, and keep the finger dry, keep the incision dry. You can do night duty, but not heavy lifting, and then take pain medication as needed. So it's not too bad. People say, oh my God, I'm going to have surgery, so I cannot do anything. I'll stay at home. What am I going to do? Usually people have some anxiety for post-operative management. Actually, for the carpal tunnel syndrome, surgery is not bad at all. We don't want you to lift too heavy for 4 weeks. And usually probably take 6 to 12 weeks, patient will do very well after surgery. So, for therapy, most time we do not recommend the patient to hand therapy. They can do this at home by themselves, you know, for range of motion, and also do some massage, you know, also for swelling. Most of the time we'll do very well without formal hand therapy for carpal tunnel syndrome. Usually after 12 weeks, probably 99% patients will do extremely well. They are very happy. So I think prevention is the most important. Every time we talk to patient, hey, to prevent this happening, you should do this. And here's some tricks here. You know, take some quick break. You know, do not do this overdo, like 3 hours like this, and rotate wrist, stretch your finger, take some pain medication, and wear the brace at night. This little thing make a huge difference. You know, people say, I don't care this, but actually these make a huge difference. I cannot overestimate, overemphasize this, like these tricks. And also avoid sleeping on your hand. You can see some scenario here. You know, when you're typing, make sure you have good positioning when you drive, and you do some stretching in the early stage can help you. And also wear the brace. See the brace, this is a neutral brace. See, this is straight. This is very important to wear this brace at night. But this is not very comfortable to wear this at daytime. But it's very important to wear this at night. Alright, we'll move on to the carpal tunnel syndrome. This is forearm again. We know we have two joints we use most often. The second one, we know this is elbow joint. And I have to tell you, carpal tunnel syndrome is the second most common, very close to the carpal tunnel syndrome, because the motion is very close to the wrist motion. So, carpal tunnel syndrome is not very common as a carpal tunnel syndrome. It's common, but not as that common. You know, we have like 75,000 cases every year in this country. We have 1.5 million cases in the whole world, and probably like 5% in the occupation. People are doing like a repeated motion with the elbow, and also man is very common than woman. This is very different from the carpal tunnel syndrome. And remember, every time if you do anything you require you flex the elbow for a long time doing this, you are going to have high risk to develop carpal tunnel syndrome. So again, let's look at what is the carpal tunnel. Carpal tunnel. You know, carpal tunnel basically is on the back of the elbow. We have you can feel like auricular. Actually, this is the tip of the back of the elbow, and also inside of the elbow we call medial condyle. Between these two gaps, this tissue cover that. That's small tunnel area we call carpal tunnel. It's here. You know, all the nerves are very small. It's probably 6 to 7 millimeters, but there are more than 10,000 fibers in this little nerve. You can appreciate how small the nerve fiber, because the nerve fiber is so small, so they are so fragile, very susceptible to any injury. You can see some mechanism here. This is the ulnar nerve come back on the elbow joint, and when you bend the elbow, you put lots of stress on this nerve. And when you put stress on the nerve, you're going to change the shape. You're going to pull the nerve, and then you can subluxate the nerve. You can move the nerve out, then cause some trauma. That's a fundamental mechanism for carpal tunnel syndrome. And this is very similar. You have high pressure, then you cause nerve compression. You have numbness and tingling in your small finger. Let's look at symptoms of carpal tunnel syndrome. You know, people complain some sensation issue in the small finger and little finger, like the case I presented in the beginning. You can see small finger here. They have numbness, tingling here. Very common. People say, "Hey, I cannot feel anything in my small finger," or the inside of the ring finger. It's very common, and sometimes we have muscle atrophy in the forearm here. Also, it's very common. If you put these two arms together, you can compare that. And you feel people say, hey, I cannot grab needle thing, my finger's so clumsy. And then sometimes the muscle will go away. You can see this patient here, the muscle. So all the muscles atrophy. And sometimes they can develop some deformity. So this is very important information here. You do not want to wait this stage. You want to treat this problem just some sensation issue. You do not want to wait, hey, I have some muscle atrophy or I have some deformity. That will be too late. Some risk factors for acute tunnel syndrome, elbow injury, and you have rheumatoid arthritis, and also some repeated pulling motion, and all this can cause acute tunnel syndrome. People using vibrating tools, and here's some scenario you can see. Someone's making phone call, talking to someone over half an hour or 1 hour. Then you say, hey, I have numbness tingling after talking with my cell phone and reading some computer and talking to people and driving and sleeping. All these are dangerous. So sleeping habit is very important. People need to pay attention to this if they have some trouble with acute tunnel syndrome, because you're bending the elbow, you're increasing the stress to the ulnar nerve. These are enemy. So for diagnosis of the acute tunnel syndrome, history is also important. You will see the numbness tingling, and also the timing of the symptoms. People say, hey, I've been talking to someone half an hour, I have this problem. This is from acute tunnel syndrome. You will do some exam, you'll see sensation change, you see muscle weakness. Sometimes you have some, we call Tinel sign, also have some exam designed to test the nerve function. We'll do this test when you come to our office. We also order some nerve study. You can see this patient have not osteophyte here because they have osteoarthritis. This causes a problem. And also we order nerve study to test the nerve function and the muscle function. Then we can give some idea, say, hey, where we are, how severe your nerve problems. Also can help to rule out other disease. So fortunately, most of the acute tunnel syndrome we can manage with the non-surgical treatment. This is very similar to the carpal tunnel syndrome. We can use ibuprofen. We can use a splint. This one we call a homemade splint. This is very effective because you just use a towel to fold and put this every time you sleep. This makes a big difference, and people like this. You change your position, some ergonomical modification. Also is very important. Probably like 10-15% people, they will end up with surgery, for multiple reasons. Some people say, hey, I'm tired of this. Sometimes just symptoms keep progressing. Then we have to release the ulnar nerve. The indication for surgery basically, they are not doing well with this bracing, with all the position change. For the timing of the surgery, I have mentioned here. For the carpal tunnel syndrome, people say, hey, can I wait for a few months? Sometimes I say, that's fine. But for the acute tunnel syndrome, usually I say, do not wait too long. Like the case I say I present in the beginning, because for the acute tunnel syndrome, the nerve from here, the distance is very long. So once you have some muscle atrophy, you wait too long, then even we do surgery, no matter what you do, this muscle will not come back. So if you say, hey, I want like a week, 2 weeks, probably it's okay. If you say, I'm going to wait a couple months, then I say, probably it's not a good idea, because you might have some muscle atrophy. Once you saw muscle atrophy in the hand, then you come back to the doctor, hey, I have acute tunnel syndrome, what are you going to do? I said, nobody in this planet will help you. The muscle is gone, they will not come back. So do not wait too long for acute tunnel syndrome. For surgery, actually, it's pretty simple. we can just release the nerve. Usually make a cut in the inside of the elbow, then release the nerve. Sometimes we move the nerve to the front of the elbow. You can see the diagram here. We move the nerve to the front of the elbow. When you flex an elbow, you have less stress to the nerve. This is some picture in the surgery. We release the nerve, we move the nerve to the front of the elbow, and put the nerve under the muscle, sometimes even fascia. Sometimes even actually we take some bone out to create more space for the nerve. It's very sometimes very extensive. So after surgery, you will expect sometimes we put a cast or splint, for a few days, sometimes 2 or 3 weeks. Then you will start to move your finger, and then we do not want you to too much weight bearing. Also, keep your wrist in neutral position to relieve the stress to the nerve. And also scar massage, because sometimes it's tender in the inside of the elbow. It's not very comfortable. Probably in 6 weeks, you will start some strengthening. I have to say, sometimes I send a patient to therapy. Sometimes they put some brace on the wrist, also for sleeve and the scar massage. Also, some sleeve to reduce the swelling. Also, we sometimes recommend scar massage. Also like walking condition activities. Need to be modified after surgery. For the recovery in carpal tunnel syndrome, actually, we have to be very, very careful. For carpal tunnel syndrome, we know, most of the numbness, tingling will be relieved, and the pain on the arm, the shoulder will get better, and the inside of the elbow will be tender, and also you might have some numbness, tingling on the backside of the elbow, which is pretty common, probably 5–10% after surgery. Then remember, the nerve regeneration is very slow. Just take 1 millimeter a day, 1 month for 1 inch. That means if you release a nerve from here, you will take probably a year. You're going to have some sensation recovery. This is very different. So because of this, you have to be careful. You do not want weight until you have muscle atrophy, because these will not come back. So this is very important information. Prevention is very important. Every time I say, we need to prevent this happen. This is better than surgery. This is better than splinting. This is some tricks here. And do not bring the arm to the table. Keep the arm straight, and slow down the activity. Also, do not use a heavy grip. You can see this here. Here's a scenario. It's very common. You see, put a pad here. Also, you can put some pad on the chair. You can put this to prevent you bend the elbow. And this is what we call a homemade brace. At night, you put the towel around the elbow so you cannot bend the elbow when you're asleep. So let's go back to my the case in the beginning. After this talk, this is a 40-year-old male, was a musician, very common, use numbness, tingling in the small finger for a month. We know this is carpal tunnel syndrome. So I talked to him. This is not carpal tunnel syndrome. This is very different. And then what kind of treatment I can offer? Say activity modification. Say you're playing guitar just every 20 minutes. Take a break. Keep the elbow straight. And at night, use like a homemade brace to keep the elbow in extension, and change your posture. Actually, in 3 months, he came back to see me, and he brought a CD for us. For the guitar, it was really beautiful. I was thinking to put that song here. I didn't do this, but that was it's a big difference, because a very early stage. This little thing make a big difference for the outcome. So he was so happy, because for him, if he had muscle atrophy, basically his career is over. So it's very, very important for him. So anyway, so when we talk about numbness and tingling, we know this is very common. We talk this every day, and we know carpal tunnel, cube tunnel, very common. We'll say, yeah, you know, you have carpal tunnel syndrome, you have cube tunnel syndrome. We know this, but you have to be very, very careful. Some problems could be troublemaker, diabetes, all these problems here and here. Actually, probably like 3 or 4 months ago, a lady came to my office. She was diagnosed with the cube tunnel syndrome. She has little numbness and tingling in the small finger. And she was diagnosed with the cube tunnel syndrome by a family doctor. Then she said, like, every time I'm holding my baby, I have numbness and tingling in my small finger. Every time. As my baby growing bigger, heavier, every time I have numbness, tingling. So I examined her. I found this is actually she had a thoracic outness syndrome. So I have to release a brachypraxis on the neck instead of the cube tunnel. I think she came to our clinic 3 days ago. She's very happy, 100%. Her symptoms is gone. So I'm so happy. So you have to be very careful. You know, numbness, tingling could be carpal tunnel, cube tunnel, also could be other problems. You know, who can help you? You need to just see us or see family doctor. They can help you. So here's the take-home message. So, you know, when we have someone with numbness and tingling, you know, when to act, you know, do not wait. It's not going to help you. And who you need to see, you know, you can see your family doctor, or you just come to see us. You know, we can help you. You know, what are you going to expect? You know, if you can see us early, we can evaluate early, we can treat you early, and the usually will recover much better. At that time, you know, the doctor's happy, patient happy, everyone's happy. You know, this will be great for everyone. Thank you very much. So this is open for